Pediatric pneumonias, the most challenging case or presentation in pediatric age group. Sometimes it becomes so tricky for a pediatrician to treat pneumonia, which is intractable even after giving or completing the course of the antibiotic, and when patient is not getting any symptomatic relief. What to do with such cases? Well, I am Dr. Kalpesh Patil, Pediatric and Neonatal Laparoscopic Surgeon working at Symbiosis University Hospital and Research Center, Pune. Pediatric pneumonias can be sometimes very tricky. Initially, the protocol is to control pneumonia or the lung infections, or sometimes the intralobular lung abscesses we can control with IV antibiotics. But sometimes when the immunity goes down or the infection flares up and it goes beyond the action of the antibiotic, in such scenario the pneumonias become more tricky and may present with pleural effusion, loculated pleural effusions, multiple septi, lung abscesses or necrotic lung patches. What to do in such cases? Because in such scenario patient become more tachypneic, there is a difficulty in breathing, and sometimes the fever is not going down, the saturation is not maintained, there is an increased demand of the oxygen while giving the treatment, and obviously a prolonged hospital stay makes everybody's life miserable, including patient. In such scenario, we definitely proceed with some kind of the investigation, and as far as the advancement of pediatric surgery and neonatal surgery is concerned, there are certain radiological investigations now easily available, like CT scan of the thorax, MRI of the thorax, which makes our life easy to diagnose the early lesions in the lungs. So, early detection of the disease and planning early treatment for the same is the only gold standard in pneumonias in pediatric. So when we suspect the respiratory distress is not responding or it is becoming intractable, early intervention is the only gold standard treatment. Many a times patient comes to pediatric surgery when patient has already taken conservative treatment for more than 2 weeks. In such scenario, the recent treatment modalities like thoracoscopy, video-assisted thoracoscopic surgeries, cannot be sometimes helpful. So, early detection of the disease can be done with the help of sonography. The sonography will detect the pleural effusion, whether there are septi present or not, whether it is loculated or not, and sometimes it may give an opinion about the intralobar abscesses, the lung abscesses also. CT scan of the thorax or MRI of the thorax will give you the exact picture of lungs and the locations of the abscesses and the necrotic patches. The early intervention with a video-assisted thoracoscopy, this can be done with only few tiny puncture wounds in the thorax rather than taking a big cut like an open thoracotomy. The advantage of video-assisted thoracoscopy over open thoracotomy is that the same results can be achieved with early recovery, minimal stay in the hospital, and the less requirement of the antibiotics, because you are decreasing the bacterial workload immediately. So, how to detect and what is the exact meaning of video-assisted thoracoscopy? So, with the 3 puncture wounds or 2 puncture wounds, we enter into the thorax with a scope, and under vision we see the loculations, we see the pleural fluid, we see the lung abscesses, we suck out all the fluid, and even we can do the pleurodesis, that is called decortication of the lung. The necrotic tissues can be taken out with the thoracoscopic procedures, and immediately after the procedure, patient can be managed in ICU with a minimal stay and can be shifted to the ward or can be discharged also sometimes early. So, pneumonias in pediatrics are very challenging and very tricky conditions to deal with when they trend to be intractable. So the gold standard treatment in pneumonias, especially in pediatric age group, is early detection and early intervention. For further guidance, you can consult with pediatric surgeons. You can visit our hospital for more information. Thank you.